Okay, so let's talk a little bit about the adenohypophysa and neurohypophysa. Now, the adenohypophysa is the anterior pituitary, namely it's in the anterior part of the pituitary, and the neurohypophysa is the posterior part. Now, each one of them secrete hormones, different hormones from around the brain that target different organs. From the adenohypophysa, namely the anterior part of the pituitary gland, we are talking about hormones such as prolactin that is secreted by the posterior lateral part of the adenohypophysa, ACTH, or maybe I will talk about each one. Prolactin, which is a hormone that usually is secreted for a lactating woman, in which it helps produce and get to the breasts of the woman in order to get milk. So it is important for milking or breastfeeding women. It can also cause problems when it is secreted from prolactinoma, namely prolactinadenoma, namely tumors that can cause vision disturbances, because the tumor, if there is a tumor of prolactinoma in the adenohypophysa, the tumor can cause compression of the optic chiasm, which is right above the pituitary. There is the diaphragm above the pituitary, and if you go up, you get to the optic chiasm, where the optic nerves cross or get together and then continue in the optic tract. And if there is a prolactinoma, it can compress this area and cause problems with vision. Okay, so we have the prolactin. Another hormone we have from the adenohypophysa, from the anterior pituitary, is the ACTH, adrenocortical stimulating hormone, adrenocorticotrophic hormone. Yes, this is the name. What he does, or what it does, is getting to the adrenal glands and cause it to secrete hormones. Especially we're talking about steroids. So when ACTH is absent, the patient can have things like Addison disease, low blood pressure, and no cortisol, no steroids in the body. Another hormone is hormones are the LH and FSH. They are secreted from the more superior part of the adenohypophysa, pars tuberalis or something like this, I'm not sure of the name, and they are important for the genital organs from the reproductive system. For example, FSH in women is important for stimulating the ovaries for follicular maturation in the ovaries, and LH in the LH surge especially is important for ovulation of the mature follicle in the ovary. It's also important in men for maturation of the sperm, but that's generally. Now, other hormones are the TSH, thyroid stimulating hormone, which is important for the thyroid gland, for stimulating it to secrete its hormones T1, T4, and T3. And when there is absence of TSH, we have hypothyroidism. It's secondary hypothyroidism. When there is no TSH, it's less common. It's less common to have hypothyroidism from lack of TSH, but that's an option if there is a problem in the adenohypophysa. I think I said most of the hormones, if not all of them, from the adenohypophysa anterior pituitary gland. Now let's talk about the posterior hypophysa, also known as the neurohypophysa. Two hormones are secreted from there. One is oxytocin, important for milk ejection from the breast, again breastfeeding, and ADH, antidiuretic hormone, which is important for preserving water from the kidney and fluids from the kidney. in order that we won't have too much urine getting out. It helps return the fluids from the tubes of the and nephrons of the kidneys. So antidiuretic hormone and oxytocin. Now, one other difference between the adenohypophysa and neurohypophysa is, or maybe before that, there is a part between the anterior hypophysa and the posterior hypophysa which is called pars intermedius or something like this, and it is also secretes hormone. It is called MSH, melanocyte stimulating hormone. Now, the hypophysa is connected to the hypothalamus, which is above the hypophysa. Infundibulum is connecting between them, and the connection between the hypothalamus and the adenohypophysa and the connection between the hypothalamus and the neurohypophysa is different. The adenohypophysa, the anterior pituitary, creates its own hormones. The connection between the hypothalamus and the anterior hypophysa is by that of neurons that gets to blood vessels, and then portal system of veins that gets to the adenohypophysa, and there in the adenohypophysa the hormones are created and secreted to the blood. This is not what is happening in the neurohypophysa. There in the neurohypophysa, in the posterior pituitary, there are neurons from the hypophysa, from the hypothalamus, that get to the neurohypophysa. I'm not sure if it's directly, but neurons are getting to the neurohypophysa and get with them the hormones, the ADH and oxytocin. And the neurohypophysa, it doesn't create any hormones by itself. It gets the hormones from the hypothalamus. Now, the hypophysa usually, if you look at MRI or CT, you will see that under the hypophysa there are the sphenoid sinuses. The hypophysa is in the sphenoid bone. Under the hypophysa there are the sphenoid sinuses, holes with air, two of them, and the hypophysa is in the center. And then above the hypophysa is in something that is called sella turcica. To be correct and to be precise, the sella turcica is the base of the area in which the hypophysa sits, but usually people call the area in which the hypophysa is sitting, lying, whatever you want to call it, the sella turcica, even though the different, let's call it, walls of the area in which the pituitary sits within the sphenoid bone have different names. Only the base, the inferior part of the walls in which the hypophysa sits in, is called the sella turcica. But nonetheless, usually all the area is called the sella turcica. Now, in this space, in the sphenoid bone, lies the hypophysa with these walls, with sphenoid sinuses inferiorly. Now, to the side of the hypophysa, to the sides of the hypophysa, namely laterally, as the hypophysa is in the medial side, median of the brain, so laterally from both sides there are the cavernous sinuses. Two cavernous sinuses at each side. Very important parts, can have pathologies, cavernous sinus thrombosis that can happen as a complication from sinusitis and things like this. Very important area with very important structure in it. What we have in the cavernous sinuses, again, laterally in both sides of the pituitary gland, there are some important structures. Let's say they maybe very important in there. There is the internal carotid artery, and there are nerves. The biggest one that you can see in imaging is the oculomotor nerve. but not also only the oculomotor nerve is there. The oculomotor nerve is in the lateral superior side. The abducens nerve, the fourth nerve, is there inferiorly to the oculomotor nerve. The ophthalmic and maxillary branches of the trigeminal, the fifth cranial nerve, are there also, again laterally and inferiorly to the trochlear nerve. And more medially, there is another nerve, cranial nerve, which is the abducens nerve, the sixth nerve. So you can understand that 3, 4, 5A, 5B branches and cranial nerve 6 are in the cavernous sinus. And of course the internal carotid artery. The fact that the abducens nerve is more medially maybe explain why abducens nerve palsy that can be caused by compression, which will cause problems with lateral gaze of the eye, or if you want temporal gaze of the eye, because abducens, as its name suggests, is responsible for abducting the eye. So abducens nerve compression can cause abduction palsy of the eye. Now, so we looked at the pituitary, the parts. Sometimes there is a cleft that is left from embryological time. I think it's called rect cleft cyst or something like this. Sometimes it even get bigger and can cause compression of the optic chiasm if it goes to the superior part of the pituitary. So we talked about the pituitary, where it sits in the sphenoid bone, what is in laterally to that, what are the parts of the pituitary, what secrete each part, how it gets its hormone or signals, and what is it connected to by the infundibulum to the hypothalamus. Now, I don't really want to talk about pathologies. I talked a little bit, but this was not the main idea of this video. The idea was to talk about anatomy and the physiology, a little bit about anatomy and physiology of the pituitary gland, the hypophysis if you want to call it. Okay, thank you very much. If there are any mistakes or correction, I'm sorry. And this was about the pituitary gland. Or maybe just another thing. If you look, let's talk a little bit about imaging. If you look on T1 without gadolinium, T1 weighted imaging on MRI, what you will see is that the adenohypophysia is usually hypointense compared to the neurohypophysia, the posterior hypophysia, which is usually hyperintense. So you see something in the sella turcica that sits there, and in the most of its part, most of the anterior, even all of it, is hypointense compared to the posterior part. Like something in the posterior part is hyperintense. This hyperintensity is the neurohypophysia, is the posterior hypophysia, which is hyperintense. And that's it. Thank you very much. If there are, when you give gadolinium, you will cause all of this to be more hyperintense, and this distinction will vanish. Thank you very much. If there are any mistakes or correction, please tell me, and that's it.